All right, so now we're recording. Let me do this. All right, we're good to go.
Great.
Awesome.
Good afternoon, everybody. Thanks for joining us. My name is Jonathan Spooler. I'm a certified peer specialist at Absolute Care, and we're here to talk to you about the Alcohol and Other Drugs Consult Team, or AOD, that we have created. It's a novel model for integrated addiction treatment in primary care. And we'll be happy to answer some questions after this recording. So bear with us. All right. So just for those of you who don't know about Absolute Care yet, we are a medical center in Buckhead. We also have other offices in Maryland and Pennsylvania. But we here in Atlanta are a primary care and infectious disease outpatient practice. We've been doing HIV treatment and prevention for a long time now. But we've also, over time, created some wraparound services. We have an on-site pharmacy. We have ancillary services such as social work, health education, and nutrition. We offer behavioral health and peer support for people living with HIV and substance use. So after hearing a little bit about Absolute Care, I'd like to introduce our team. First up, we have Dr. Ryan Grady. If you'd like to say a few things about yourself.
Yep, so hello everybody. Thanks for listening. My name is Ryan Grady. I'm a primary care internist. I'm also board certified in addiction medicine. I practice HIV, hepatitis C, and addiction-related primary care, as well as general primary care at the Absolute Care Atlanta office. And prior to my time here, I had spent 3 years at the Johns Hopkins School of Medicine in the Division of Addiction Medicine, doing similar clinical work. I'll hand it off to Corrine to introduce herself.
Hello, everyone. My name is Corrine Jones Williams. I'm a licensed clinical social worker as well as a certified anger management specialist. I have vast experience and expertise with adults living with trauma, PTSD, mood and psychotic disorders, as well as substance use, in addition to co occurring disorders. Past experience includes inpatient and outpatient settings, community based support, structural project and model development, as well as clinical case management. In my role at Absolute Care, I am one of 2 behavioral health consultants that provide short-term therapy to our members and patients at our Atlanta-based location.
And as I said earlier, my name is Jonathan Spooler. I'm a certified peer specialist. So what that means is that I have lived experience with addiction. I also have lived experience with depression and suicide attempts. I'm also a person living with HIV. So what I do at Absolute Care is use that lived experience to help people who are going through similar situations kind of figure out how to navigate that landscape, how to set goals, how to create coping mechanisms, and how to understand the process of recovery and what some of the pitfalls are, and help them create strategies that can move through those stages with relative ease. My bachelor's is in voice performance. I'm relatively new to the recovery scene, so I tried to make music work for a while. But after my bout with addiction, I started working at Absolute Care, and I really came to love the way that wraparound services can really lift people up. And we're going to talk a little bit about how that works, particularly with our team today. So thanks again for being here. That's our team. We're going to move forward. So what is the Alcohol and Other Drug Consult Team as far as how it is applied in a primary care outpatient setting? We have integrated addiction medicine services into a primary care setting. We believe it's very crucial for expanding evidence-based, low-threshold treatment for people who use drugs. We're a novel multidisciplinary team embedded within an urban primary care and infectious disease practice in Atlanta. I'd like to go ahead and hand it off to Corrine. She is going to talk over some presentation objectives and kind of give you an idea of where this came from and you know what we've discovered as far as need is concerned here.
Thank you, Jonathan. So just to go over our presentation objectives and things that we're going to discuss today, our hope is to, within our time, is to review the role of our primary care for people who use drugs, as well as give a more in-depth understanding of our multidisciplinary model and how it is integrated with addiction medicine. We also will go into more specifics of our individual roles and how we support our members. In addition to that, following that, we will definitely discuss our outcomes, the trends and experiences that we have run into in our observation as a team, as well as reflect on the lessons that we have learned as we have built our program. And lastly, we'll try to show and present our successes and benefits of our consult team to our members at Absolute Care. If we could go to the next slide. So, in looking at the origin of this work, what we decided and the members of our staff is that we needed an option for our patients to provide wraparound resources in our practice. Prior to the program beginning, there were no particular options for our members that focused specifically on substance use concerns. With our widespread provider awareness of active substance use among our individual patients, we saw the need for substance use being supported. Substance use and other disorders has been a major co-occurring or contributor to morbidity and mortality in our practice, thus needing an opportunity to align internal resources for medical support to offer substance use to our members and as well as linkage to care for other options. Looking at the need of substance use in Atlanta and Georgia at large, there are a myriad of social problems that can and do instigate concerns and social problems that make it difficult to access care for substance use concerns. Specifically to our members, looking at our HIV population, the lack of affordable housing, gaps for our inclusive services for our LGBTQIA+ populations, and an increased use of methamphetamine use for our members, and finding a standard of care for our methamphetamine use members. And then also seeing that there's a lack of access and visibility to treat not just methamphetamine, but also all substances for our members.
So at this point, I'll talk a little bit about the role of the primary care provider kind of broadly and how it, I think, nicely fits in to our model of an AOD consult team that's multidisciplinary. And so I think of the role of the primary care provider as at least fourfold in the delivery of care. I think, first and foremost, primary care providers, whether they're nurse practitioners, physician assistants, or physicians, are really the first line providers for non-emergent care in settings where people have access to primary care. And we know that that is and continues to be a major issue, the access to primary care. But in settings where people have access to primary care, we're really that first line provider for things that don't require an emergency room visit. And so, we see a broad array of different disease conditions, both acute and chronic. And because of this role, often in the care of chronic diseases, primary care providers often become longitudinal partners with patients, right, over the course of their life, over the course of a disease process, and over a number of different changes in terms of living situation, sort of job, retirement, and other things throughout their life course. Another important role for primary care providers is really as a care coordinator or quarterback of care. So a good primary care provider is really kind of the point person who determines sort of whether a patient needs to see specific specialists or other often non-medical services, things like physical therapy, nutrition, therapy, etc. and is really someone who can, because of that role as the quarterback and the longitudinal partner, be an advocate for patients as well. Primary care providers are often the person within the healthcare system who knows a patient best. So when patients are hospitalized or patients see other subspecialty providers, they can provide insight into the patient to help improve their care and also to advocate for them. And I think for all of these reasons, it really makes sense for the primary care provider to play an integral role in the treatment of addiction for patients who have substance use disorders. I'm going to briefly introduce the structure of how we take consults for a multidisciplinary team. So again, sort of the three of us and one of our other behavioral health therapists who's not on with us today work together to provide care for teams who are patients of our infectious disease or primary care providers within our practice. The way that we take consults within our practice is for patients who are already members within our network. Really anyone in the healthcare team or the patient themselves can refer them to our services in AOD, so that everybody from medical assistants and nurses to our social workers and nutrition, obviously the providers themselves and patients can self-refer. So we're pretty open and have made ourselves known across the group of people who work in our practice to be available. Jonathan, our certified peer specialist, is really kind of the point person for triage and the first stop in general. If someone has a patient or is interested in seeking services themselves, he will do a detailed intake with patients who are agreeable to work with us, and then works with our behavioral health therapists and with me to determine what additional needs patients may need. So specifically, patients who have concomitant psychiatric disease, right, dual diagnosis patients often benefit from behavioral health. People who are suffering from adjustment disorder or other acute anxiety or stress, often related to substance use, often benefit from behavioral health therapy as well. In terms of patients who see me, typically that's patients who are being evaluated for medications for addiction treatment, for things like alcohol use disorder and opioid use disorder, for which there is well evidence-based medication-based treatment. Also, patients who have acute and chronic issues related to drug use, so things like recurrent cellulitis or abscesses, long-term sequelae of endocarditis related to injection drug use, are often referred to me for ongoing treatment too. And I think one thing to highlight here is that this really isn't a one-way street in terms of Jonathan evaluating somebody and then sending them off to one of us. And we all work together and communicate pretty openly about patients, at different points in the trajectory of someone's substance use. They may have behavioral health needs that then resolve and sort of may periodically need to be revisited, but aren't something that's active. And so I think, later on, we're going to talk a little bit about some examples of patients that we've collaborated on as a team specifically that have been particularly successful, and you'll get a sense of that. But there's a lot of crosstalk between all of us, which makes the team work. So in terms of specific roles for the three groups within our multidisciplinary team, just to highlight some of the things that I've already kind of glossed over, but so I, as addiction medicine trained primary care provider, am really here to provide this empathic, evidence-based primary care with this emphasis on treatment of substance use disorder and the complications. Also serving in my primary care role as a quarterback for coordinating the team generally and addressing any medical concerns that come up. Our behavioral health consultants are really there to help to provide relief of behavioral health related symptoms, including things like stress, depression, and anxiety that often accompany problematic substance use and or addiction, and help patients to develop coping strategies to deal with some of the things that they're dealing with. And the goal really is to work with members to change the state of distress, right, that's really bothering them and that has caused sort of injury to them in many ways. Our peer, Jonathan, is really an advocate, right, who can connect in ways that the rest of us just aren't able to because of his lived experience, and is someone who can therefore empower members to address and sort of motivate people to live healthier lives. And he is a lot more versatile than the rest of us in terms of providing both in-person and by phone support and outreach, regardless of where the member is. With the coronavirus pandemic, this has become a little bit more limited in terms of mostly occurring over the phone these days, but he is able to reach out into the community nonetheless in ways that the rest of us just aren't able to. So I'm going to hand it back to Corrine, who's going to talk to you a little bit more about some data and marketing.
Thank you. As we developed the consult team and we built the structure and tried to identify what steps to take, we also had to think about how are we going to notate our progress, how are we going to spread the information, not just internally, but externally, but also to not just our internal providers, but also to community, other community providers and facilities. So with that, we had to think of a few things to think of, not just keeping up our data elements to track and trend our work, also finding a significant place so that we can update that data in real time. And then also, how do we present ourselves and the services that we are providing to our providers internally and to the community, and also not for the things that we're not able to provide internally, how can we provide those resources to our members in the community to get them connected to care outside. If we go to the next slide. So when looking at our data points and trying to identify what is the information needed to track our patients and our progress, we created an internal tracking tool on SharePoint to capture data about our consults and outcomes. Specific things include not just the provider, the beginning of the service, the referral and where it came from, the initial date of contact, substance use, HIV status, as well as who they were connected to. So were they connected to myself and our other behavioral health consultant? Were they connected or working with Dr. Grady for addiction medicine or MAT? Also, our certified peer support services, how are they connected to Jonathan and how often? And then over time, at about 6 to 8 months, we looked at what is our progress and where our patients are in their substance use. Are they active, inactive? Has it been abstinence? Has there been abstinence? And then also, if coming from that information and our data points, we looked at, okay, how can we reevaluate our patients and to provide the continued support internally or externally with appointment follow-ups. Next slide, please. In marketing our efforts, we were provided by our marketing team handouts and templates of pamphlets to provide our community resources. So what that included was digital printed ads, and then also myself and Jonathan took time each month to go to various local hospitals, inpatient and outpatient behavioral health or substance use facilities, HIV advocacy organizations, LGBT advocacy organizations, and specifically with Jonathan, who has been a great support with Atlanta Harm Reduction Coalition weekly by reaching out to members of the community, not necessarily affiliated with Absolute Care, but also to provide that outreach and support to show that Absolute Care can be a provider, not just for substance use, but also for medical needs and concerns as well. And on our printed and digital ads, you can see all of the things that we offer, how to refer to us and to get things started, and what insurances that we provide in our individual contact. And looking at linkage to care, areas of opportunity for our partnership is very important. It's something that we're looking for, if not daily, weekly. We're trying to look at ways to connect our members for other HIV resources. Housing is very important. Our social workers work diligently on that, as well as any resources that is available for the LGBTQIA plus community. In addition to that, I work as well to find other mental health supports that could be inpatient, outpatient, intensive outpatient, or maintenance support, and also substance use needs support groups, and specifically psychiatry. Psychiatry is something that we are working to find diligently for our members, because that is sometimes support that we're not able to provide, but we do the best that we can with our providers to provide that supplemental support as needed.
So I'll go on and talk a little bit about the program results that we've had so far. So we'll go through some data slides here, just to give you a sense for kind of the volumes and types of patients that we've been seeing in our consult team. So we've now been up and running for almost exactly a year. We started in August of 2019, and you can see the data here is complete through July of 2020. So these are the number of referrals that we received per month over the course of that time. You can see, you know, there's been a little bit of a lull with the onset of the coronavirus pandemic, and we as a team have been working internally to try to figure out sort of ways to mitigate that, and how we can continue to reach the people that we know that are out there that could benefit from our services. This is a breakdown of the types of substances that are used by the people who have been referred to our team. So you can see we've had a total of 55 referrals over the course of the last 12 months. About a quarter of those individuals are using more than one substance in the polysubstance use category. And then in terms of specific substances that are used, the most common substance used that we see is stimulants. So we see a large number of patients who have methamphetamine use disorder. The second most common substance that we've seen patients using is alcohol. So about a third of patients referred to us have concerns related to alcohol use. Of note, that number has been increasing significantly during the pandemic. We've seen an uptick in patients referred to us for concerning alcohol use, which seems to mirror some of the national trends that have been reported. And then you can see just under a quarter of patients referred to us have opioid use disorder, or have concerns related to opioid use. As Jonathan had mentioned early on in the presentation, we're a multi-specialty practice with infectious disease providers and primary care providers. The majority of our patients in the practice are living with HIV, and this is reflected in the breakdown of HIV status among patients that are referred to us as well. If we look at the services provided, so this is the number of clients or patients that each of us has seen over the course of the year. So not every patient, you know, needs the full complement of seeing the three of us as part of support for their alcohol and other drug use. But generally speaking, we have fairly even burdens in terms of the number of patients that we're seeing, you know, between 25 and 30 or so among all of us. Individually. In terms of medications for addiction treatment, this is specifically for patients on treatment for alcohol use disorder and opioid use disorder. We have about 12 patients that have been seen on MAT, and then just under 10 patients have been referred externally to additional services outside of our organization. That may include inpatient detox facilities, intensive outpatient programs, or other outpatient resources that we're not able to offer in-house. This is the volume of visits monthly by provider type over the course of the past 7 months. And you can see the number of visits by the number of visits conducted by Jonathan in blue, by Corrine and her behavioral health consultant colleague in orange, and then by me in gray. And you can see, you know, fairly consistent numbers over the course of the past few months, with maybe a little bit of a drop off in July across all of us in terms of volume. Jonathan, our peer, which would be expected, has been seeing the most clearly the most has the most volume of visits of all of us, and he has a number of patients that he does see that he talks to weekly. And then this is a pie chart that looks at self-reported substance use relative to baseline. So among patients who have had at least one touch, one visit with someone from our AOD team, we here are illustrating sort of what self-reported use is among patients who have had an experience interacting with us. You can see that the good news is, so no one is reporting an increase in substance use relative to baseline. That's the 0% up here. 14% of patients who have interacted with us say they're using, the substance of concern about the same as they were prior to interaction with us. 18% have reported a decrease, 39% report abstinence, and there are a fair number of patients who are lost to follow-up. So, just over a third are unknown. But I think just to highlight here, right, across all people who have had at least one touch with our AOD consult team, we're seeing a 57%, or 57% of those individuals report either a decrease in substance use or abstinence. So over half of the patients who have a touch with us are reporting decrease, use, or abstinence. With that, I'm going to hand it off to Corinne and Jonathan. They're going to tell you a little bit about some of the stories of success that are sometimes a little bit richer than just showing you the data. So I'm not sure who is going to go first, but I'll hand off to you guys.
Okay. Well, Jonathan, if you'd like.
Sure. I've got two people I'd like to highlight. One is a gentleman who was struggling with crystal meth use for a number of years, pretty much daily use. And he came to me right when he had entered a sober living facility. And that was his first time really stopping. And he was struggling with trying to re-enter society. There were some things in the sober living facility that weren't working out. So he had these fears around lapsing or relapsing. And so we really got to talk together about how he could create strategies to cope with the stress and the things that he was going through. My lived experiences with meth use. So we really connected on understanding, just some of the things that are happening to you, and how you're reacting to stress. So I'm happy to say he has been abstinent for several months since he entered the sober living facility. He's moved back in with his partner, and he has a job. He's up for promotion. He's stressed out about the news in the world, but he is coping with all of that in really healthy ways and has remained abstinent from crystal meth for, like I said, a number of months. The other gentleman he came to me with some concerns about his alcohol use. And he wanted to get to a place where he could use socially, but he wasn't using every day. And he has reduced his use to just weekends, Friday, Saturday, and Sunday. And he has reduced his use on the weekends so that he is, say if he's at a bar, he has a drink, the next thing he's drinking is club soda or water. And so he's created these strategies to reduce the impact of his alcohol use as he wanted it to be. He's also talked to his partner, his husband, about his needs around it, because his husband's goals aren't the same. So we talked about ways that they could communicate, their needs to each other. And I'm happy to say he's happy where he's at.
Oh, good. Thank you. A member that we have also worked together with is just to give some demographics, he's a 43-year-old African-American male who joined Absolute Care in February 2020. Including his initial assessment, we have virtually met about 4 times since June of this year. Initially, he expressed feeling pressure of COVID-19, working from home, the national racial distress, which increases anxiety. In addition to this, he was also assisting his stepfather as a caretaker for his ill mother, who lived outside of Atlanta, which has also been a major stressor as well. He expressed using alcohol as a relief of stress and frustration. Also, smoking marijuana since about the age of 15, despite about a 6 year gap of not smoking. With his emotional and behavioral history and his historical and current substance use, there's definitely a presence of, depression, alcohol use, and cannabis use all on a moderate level. As a behavioral health consultant and therapist, we discuss potential harmful effects of stopping drinking abruptly and ways to decrease his usage, and thinking of the consequences and reasoning for his drinking before even purchasing alcohol. Um, and that kind of it's helped him to process his thoughts on, okay, why am I drinking? Do I really need to drink? Is this going to help get rid of the stress and the tense times, as well as discussing ways to manage his emotional triggers that lead to the stress and anxiety and frustration. In our sessions, in assistance with Dr. Grady, he has shared that in our last session, the success of decreasing his alcohol intake, which was his main concerns substance-wise, outside of the emotional support that he needed. This in turn also helped him to refocus on himself and the needs he wants to address, to better his efforts, not just sobriety per se, but decreasing his alcohol intake. And then another major support that he often shared is the peer support with Jonathan that he speaks to frequently, and using therapy as a support in addition to the peer support, has been substantial for him and has been a major change. And he often expresses his appreciation for us as a group and a consult team, for his progress today.
Great.
And I don't know if Jonathan, if you have anything, because he talks so much, so many great things about me. He's like, I'm going to talk to Jonathan this week. So he
No,
definitely finds supporting you.
so we often have conversations about the stressors that are occurring in his life, and how his alcohol use is both affecting those and is affected by them. And so it's been really great to watch him kind of think critically about his alcohol use and what role he wants that to play in his life. So I've just been really impressed by his willingness to open up and think, about his use in ways that I don't think, a lot of us who use necessarily understand at first. Sometimes maybe never. So it's been really great working with him. I'm very impressed with the progress he's made.
Thank you. And if you would like to move forward with our lessons.
Yeah. So
Let me
um,
and
oh,
let me just say I don't want to leave the slide without making one mention of another patient that I think is a great success story that Jonathan and I have both worked with. He's a man in his 60s who has severe underlying psychiatric illness that's untreated, as well as severe opioid use disorder and cocaine use disorder. He was somebody that Jonathan had actually met at one of the outreach syringe exchange days conducted by AHARC, and was linked to our service for treatment for opioid use disorder as well as primary care. We had met him in November, or I'd met him in November of last year, and he had actually recently had an unintentional overdose. So he was a guy who had had at least 30, 40 years of intermittently, sporadically treated opioid use disorder with injection drug use, and had recently had an overdose prior to his linkage to care with us in November. Jonathan was able to link him by virtue of his participation in outreach. And so he saw me for primary care and for treatment of his opioid use disorder. We got him started on buprenorphine with very close follow-up and regular visits with Jonathan as our peer as well. He had one subsequent unintentional overdose in January of this year, but since January has not had any overdoses, has been adherent on buprenorphine, has attended appointments consistently throughout the pandemic, despite unstable housing, and like I mentioned before, pretty severe undertreated psychiatric disease, which we're still working on him with. So in addition to not having any unintentional overdoses since January of this year, he's also self-reported that he stopped injecting, period, when he uses heroin. So he's using intranasal heroin, snorting only, has cut back on his cocaine use as well. And like I mentioned, has been adherent on the buprenorphine. Our AOD consult team has a strong philosophy of encouraging harm reduction. And so, the goal for him may not necessarily be complete abstinence at this point, but at least working with him to reduce some of the severe immediate harms, including things like unintentional overdose and consequences of his injection drug use, for which he has had multiple abscesses and hospitalizations in the past. So he's somebody that's actually been, I think, a pretty inspiring story of success, although sort of still a lot to work on for both of us. And I don't know, Jonathan, if you wanted to talk briefly about him.
Yeah, no, I think you touched on all the points. He's amazing to me because he really is engaged in trying to reduce this harm to himself that he acknowledges, and he's got all of these things going against him, and he's one of the most tenacious people I've ever met, and his engagement in his care is inspiring, because I know that when I was experiencing some of the social determinants of health that he's experiencing, that I had a hard time motivating myself to engage in anything, especially treatment or care that could help me through my substance use concerns. And so watching him really dig in, and if he doesn't make it one day, he's going to make it. We know he's going to show up, and that's what matters. So I've been just really inspired by him.
Great. All right, now we can move on to lessons.
Thank you for that. Okay, so some of the things that we have learned through this process, as anyone does, creating something new and seeing how it unfolds, are that it's really crucial to be flexible. People have life events, and I think people who have substance use concerns often have unpredictable lives. And so I can say that from my own experience, and obviously that's not for everybody, but really being able to kind of accommodate people where they are in their life, and accommodating them in a way that gives them the direction. They get to choose what it is they think they need, where they want to go, what kind of referrals they want out. And so it's really important to be flexible. It is very challenging sometimes to keep people engaged. We've had, well, and as you noticed earlier, there's that segment of people that we don't know what their substance use is right now relative to the baseline when we first touch base with them, a little bit over a third. And so trying to keep in touch with some people who might have more rocky living situations right now, or any other determinants that can create that instability or makes it hard for us to keep in touch with them, has been a challenge, and we're constantly trying to think of ways to keep up with that. There is a significant need for a standard of care for stimulant use, particularly around methamphetamine. We are constantly trying to find resources, and I think, you know, one of the challenges is that we just don't have a whole lot of research in being able to treat it. There's no standard for MAT for methamphetamine or other stimulant use. So just really trying to create a landscape that's equally supportive for stimulant use as we have for alcohol and opioids. You know, we have those gold standards of care. And understanding that recovery looks different for different people. Like Ryan said earlier, someone's recovery goals may not be the same as somebody else's. You know, somebody may decide for themselves that they need to abstain from their drug of choice or all substances. And somebody may decide that they just want to reduce their use so that it's not impacting them as negatively as it had been. So really allowing people to dictate that for themselves. I found that if you push one ideal on somebody, that can create some resistance in some ways. So we really try to meet people where they are, which is the exact next next point. So not everybody's ready to make huge changes right away. And for some people, you know, incremental change over time can really like boost success. So if you can achieve a small goal, that can prove to you that you can continue doing that to meet whatever that next big goal is. And also understanding that people are going to be in different places in their lives. And so we want to meet people where they are so that way we can best accommodate their needs and make sure we're supporting them in the ways that best fit what's going on. Creating a safe, non-judgmental space is key. If our members don't trust us to be empathetic, to understand that what they're going through is hard, to honor their choices, that can create a breach in trust, which you know will keep members unengaged and maybe push people away so that they're, you know, not wanting to engage in care. We are also anticipating pharmacy-related barriers, access to things like naloxone. Although Atlanta Harm Reduction Coalition has been key in making sure that the communities have access to free naloxone if they don't have any other way to get it. So building that and making sure that people who need access to MAT or overdose prevention tools can get that access. And then really being trauma informed in all of this and understanding how trauma and other social determinants of health affects people and their outlook in their care, and being able to meet them there and talk about that. And that understanding really gives us an edge because people feel heard, people feel safe. They feel like they can really dig their heels into the things that are making this hard for them or harder than they want it to be. And us being able to understand that and empathize with it gives us the ability to work with people in a way that can move past them or address them in healthy ways. So what we're trying to do, kind of ambitiously, I guess, is to really bring this outpatient addiction treatment into primary care settings. It helps close gaps in care. It really helps primary care physicians better understand their members and their members' needs. And that's what we've learned, is that we had all of these great wraparound services, and this was the next logical step in that evolution. It has given us the ability to really get into our members' care and understand that this one aspect can affect their entire lives. And as you know, a preventative disease, a preventative model, primary care is hopefully disease prevention or maintenance. We can help them recover in a place that they already feel safe. And then also provide resources for anything that we're not able to do, which is why we're reaching out into the community. So our goal is to provide support in the primary care setting for addiction and substance use, and create this network in the community that can support people in an effective way. So we are going to end this recording and take some questions live. So thank you for being here, and we'll look forward to answering any and all of your questions. Thanks.